Hey there, and welcome to this explainer. So, quick question. What common antibiotic can actually cause a sudden, catastrophic Achilles tendon rupture? I know, it sounds like some bizarre medical mystery, right? But it's actually a highly testable, absolutely crucial reality in clinical pharmacology. Today, we're going to unlock the answer to this, along with a bunch of other high-stakes clinical scenarios. Think of this explainer as your personal clinical safety rounds. We are stepping right into the high-stakes world of renal and urinary pharmacology. And look, your knowledge here doesn't just help you pass exams, it literally protects your patients from severe, sometimes life-threatening complications. We're going to skip the basic fluff and master the critical safety priorities, the strict contraindications, and those classic clinical traps that honestly try to trip up even the most experienced pros. All right, let's take a quick look at our agenda for today. First up, we've got localized versus systemic anti-infectives. Then, we'll dive into bladder function and some severe cases. And finally, we'll wrap it all up with a high-yield practice quiz. Okay, let's jump right into Section 1, localized versus systemic anti-infectives. So let's look at the localized disinfectants first. These are drugs that inhibit bacterial growth right there in the urine, but they don't really reach effective antibacterial levels in your blood or tissues. First up is fosfomycin. Now, the strict prep here is absolutely key. It comes as these granules that you have to dissolve in exactly 120 milliliters, which is about half a cup of cold water. You stir it well, and the patient has to drink the whole thing. Next is methenamine. This one needs an acidic urine environment, so a pH of 5.5 or lower to actually work. But here is a massive clinical caution for you. It decomposes to generate ammonia. Because of that, it is strictly contraindicated in clients with liver dysfunction. You just can't risk it. But we need to urgently pivot over to nitrofurantoin. You've got to teach your patient that while a brown discoloration of their urine is completely harmless, they need to be hypervigilant for severe pulmonary hypersensitivity reactions. We're talking dyspnea, chest pain, chills, fever, and a new cough. These could point to alveolar infiltrates, and that means stopping the drug immediately. Now, let's directly compare our heavy-hitting systemic options. For fluoroquinolones like ciprofloxacin, you really have to watch out for that Achilles tendinitis and potential tendon rupture we mentioned earlier. And that risk absolutely skyrockets for clients over 60, anyone taking corticosteroids, or organ transplant recipients. Oh, and keep an eye out for CNS toxicity too, like dizziness and visual disturbances. On the flip side, we have the sulfonamides, like trimethoprim sulfamethoxazole. The absolute glaring red flag here is Stevens-Johnson syndrome. It's a severe, widespread skin and mucous membrane hypersensitivity. Literally, if your patient on a sulfa drug reports a rash, you withhold that medication immediately. No questions asked. You also need to monitor for dangerous blood dyscrasias like agranulocytosis. A seemingly simple sore throat or a mild fever, that's a reason to call the provider right away. And remember, both of these drug classes require massive fluid intake, at least 1,200 to 1,500 milliliters of daily output, just to prevent crystalluria. Moving right along to Section 2, bladder function and severe cases. First up on this list is phenazopyridine. You need to heavily emphasize to your patients that this only treats the pain and burning of a UTI. It does not treat the infection itself. And please be sure to warn them that it's going to turn their urine, their tears, and even their contact lenses a bright red or orange color. It's harmless, but definitely startling if you don't expect it. Next is oxybutynin. This is an antispasmodic for an overactive bladder. Because of its anticholinergic properties, it actually blocks the flow of intraocular fluid. Because of this, it is absolutely contraindicated in patients with narrow-angle or open-angle glaucoma. It can spike that intraocular pressure and permanently damage the optic nerve. Finally, we have bethanechol. This is a cholinergic used to increase bladder tone in non-obstructive urinary retention. Basically, you're forcing the bladder to contract. Because of this, you've got to monitor for a cholinergic crisis. Think bradycardia, hypotension, and just excessive salivation. And always have the antidote atropine sulfate readily available. Now, when we transition to organ transplant patients, precision is literally everything. Lifelong immunosuppressants like cyclosporine and tacrolimus have to be taken at the exact same time every single day. This ensures the immune system stays suppressed enough to prevent organ rejection. But cyclosporine is highly nephrotoxic, so regular BUN and creatinine checks are absolutely mandatory. And don't forget the dietary ban. Consuming grapefruit juice is strictly prohibited. Why? Because it spikes cyclosporine levels and massively increases the risk of toxicity. Finally, for patients dealing with anemia from chronic kidney disease, we use hemopoietic growth factors like epoetin alpha to stimulate red blood cell production. But here's the catch. As those red blood cells increase, so does the blood viscosity. That makes hypertension a major critical adverse effect that you have to monitor for. All right, let's wrap this up with Section 3, our high-yield practice quiz. It's time for our interactive clinical safety rounds quiz using the 5-second rule. Get ready to test your critical thinking and apply everything we just talked about. Question 1. A client with a cold shows up in the emergency department with an acute inability to void. Because this client has a history of benign prostatic hyperplasia, or BPH, the nurse determines that they should be questioned about the use of which over-the-counter medication class. Is it 1. Diuretics, 2. Antibiotics, 3. Antilipidemics, or 4. Decongestants? Look out for that classic clinical trap regarding BPH here. All right, you've got 5 seconds on the clock. Lock in your clinical decision. And the correct answer is 4, decongestants. Decongestants are the culprit here because they contain alpha-adrenergic agonists. These agonists actually cause constriction of the bladder neck and the urethra. So in a client who is already dealing with an enlarged prostate, this added alpha-adrenergic stimulation just clamps down on the urethra, precipitating a really painful episode of acute urinary retention. Moving on to question 2. Nitrofurantoin is prescribed for a client with an acute urinary tract infection. The client contacts the clinic nurse and reports a new cough, chills, fever, and difficulty breathing. What is the most appropriate next action? Do you reassure the client, instruct them to stop the medication immediately, advise an OTC remedy, or tell them to take it with milk? Pay attention, this is a critical safety priority scenario. Take 5 seconds to identify the absolute red flag here. The correct answer is 2, stop the meds immediately. And honestly, this brilliantly illustrates why recognizing pulmonary infiltrates early is quite literally a matter of life and death. These symptoms indicate a severe acute pulmonary hypersensitivity reaction. This requires the immediate cessation of the drug to prevent permanent, irreversible lung damage. Here is question 3. Trimethoprim sulfamethoxazole is prescribed. Which of the following symptoms must the client report immediately if it develops during therapy? Is it 1. Headache, 2. Sore throat, 3. Diarrhea, or 4. Nausea? Think back to those systemic antibiotics and their most dangerous toxicities. You have 5 seconds to spot the early warning sign of bone marrow suppression. The correct answer is 2. Sore throat. A seemingly simple sore throat or fever in a patient taking a sulfonamide is actually a massive red flag. It's an early clinical warning sign of severe hematological toxicities, things like bone marrow suppression and agranulocytosis. The provider has to evaluate their white blood cell count immediately. Question 4. Phenazopyridine is prescribed for a client with an acute UTI. How do we evaluate that the medication has actually achieved its intended therapeutic effect? Is it 1. The urine is red, 2. Urination is no longer painful, 3. Urging continence is gone, or 4. The urine is clear? Make sure you don't fall for the visual distractor in this question. 5 seconds to determine the true therapeutic effect. The correct answer is 2. Urination is no longer painful. Remember, the red-orange discoloration of bodily fluids is just a harmless side effect of the dye in the medication. It's not proof that the drug is actually working. Because phenazopyridine is strictly a localized urinary analgesic and doesn't treat the infection itself, therapeutic efficacy is purely about the relief of pain, burning, and urgency. And now for question 5, our final question. Bethanyl chloride is prescribed for a client experiencing urinary retention. Which condition is a strict contraindication to this medication? 1. Gastric atony, 2. Urinary strictures, 3. Neurogenic bladder atony, or 4. GERD. We're administering a powerful cholinergic to increase bladder tone, so what is the absolute worst-case scenario here? 5 seconds to lock in this critical, high-yield contraindication. The correct answer is 2. Urinary strictures. Because bethanyl acts to powerfully contract the detrusor muscle of the bladder, forcing a bladder to contract against a physical wall, like a stricture or obstruction, well, that's just a recipe for disaster. It can lead to extreme pain, vesico-urethral reflux, or literally even bladder rupture. Knowing these mechanisms inside and out is exactly what keeps your patients safe. So will you remember these clinical red flags to protect your patients on your next shift? Keep reviewing, stay focused, and I'll catch you in the next explainer.